Excellent. Hello, my name is Dr. K. My name is actually there down at the bottom. It's really long, so Dr. K probably is better than Schersager. But I'm a third-year resident at VCME, Valley Consortium for Medical Education. It's a family medicine residency program here in Modesto. We're primarily based at a doctor's medical center as well as Paradise Medical Office. Those are the two clinical sites that we basically are at. And I'm happy to be here to talk to you guys about long-acting reversible contraceptives, or LARCs. Let's see if this works. It does. Excellent. So this first slide is something I just like to look at before I start talking about contraception. It looks a little bit crazy, but the things to really keep in mind are the top section, which is basically the ovulatory cycle or ovulation. And then there's this middle section where there's like the blue and green lines, the orange and purple lines. And those are representative of hormones that are basically going through a woman's body when ovulation is occurring. And the very bottom one's also, in my mind, very important because it basically shows the uterine lining. So just to give you kind of a basic overview of what happens during ovulation is in the first 14 days, you have, if you kind of look at the orange and purple section, you have this jump in estradiol or estrogen. And that kind of coincides with these other two hormones, luteinizing hormone LH, which is the blue, and follicle stimulating hormone, which is FSH in the green. And when all three of those basically spike, you have this this follicle that's developing into an ovum, into an ovary, not an ovary, into an egg. And that egg is actually released at ovulation. And that's right at 14 days. Following that, as you can see, after that really big spike in estrogen, you have a rapid drop in it, and then an increase in progesterone. So if you kind of look at the bottom part of this graph, you have this increase in thickness of uterine lining, and that keeps increasing up until about 28 days. And that's right around the time when menstruation happens. So you basically shed that lining. And this in and of itself is like a very basic version of what happens during ovulation, but I thought it would be interesting and appropriate to include this when I'm talking about contraception. Let's see if I can move this in the right direction. Yes, I can. So I included three just really basic pictures of different contraceptives that we use in our clinic. The one on the left is a Nexplanon, also called an implant or an implanon. It used to be called an implanon a couple of years ago. The one in the middle is a hormonal IUD, and the one on the right is a copper IUD. So those are the three ones that I'll be talking about primarily today. So who is qualified to get these as contraceptives? So a majority of women actually qualify to get these. I included very basic information in this slide in terms of what benefits people might see out of getting each of these contraceptives, but just to kind of break it down a little bit. Nexplanons, there's a low dose of hormone, primarily progesterone, that's going through your body. And if you want to avoid estrogen-based contraceptives and you want long-acting reversible options, Nexplanon may be an option for you. There are some caveats to that. There are very small proportion of the population that it's actually not indicated for. So specifically, actually all three of these have the same indication, but if you're pregnant, obviously it doesn't qualify you to have this. And then if you have extensive blood clotting disorders or severe liver disease, and in addition to that, if you have known history or current breast cancer, those are reasons why you shouldn't be getting the Nexplanon. But for the most part, everyone else is actually in a category where they could be able to get it. The other two are the IUDs. Hormonal IUDs, it's if you're looking at it from a pro standpoint, women that want to reduce potentially menstrual bleeding or low blood counts or anemia, the primarily component of this IUD is levonorgestrel, which is also progestin or progesterone based. So it can reduce menstrual blood flow. You could have a stopping of your period, also called amenorrhea, and it might also decrease the painful, crampy periods that some people may actually get, also called dysmenorrhea. Then from a copper IUD standpoint, if people want to avoid hormones altogether, there's no hormones based at all within the copper IUD. It could be for a variety of reasons, either for personal preference if you don't want to have a bunch of hormones in your body, or if you have a very strong history of breast cancer in your family. Those are options for maybe wanting to go towards a copper IUD if you want that same long-acting reversible contraceptive method. And then if you want to stay protected from pregnancy for a very long period of time, the copper IUD is actually one of the longer ones that we have. It's up to 10 years that can be used. So those are kind of just general ideas of selection and between those three in particular. And the other thing that's interesting about the copper IUD, it's actually the only one on this list that can be used for emergency contraception. And you can actually place it within 120 hours or 5 days of unprotected sex. And it's about less than a 0.1% pregnancy rate in that window. Obviously, reasons not to get an IUD if there's a very severe distortion of the uterine cavity, if you have an acute pelvic infection, something like something called PID or pelvic inflammatory disease. If you have something along those lines, those are indications not to get the IUD. And then other things that are a little bit more rare. So if you have like copper overload, like Wilson's disease, or if you have current breast cancer, those are reasons not to necessarily get the IUD in particular. But everyone else that I didn't really mention, they generally qualify for these birth control methods. So how do these things work? The Nexplanon, since it's a progesterone or progestin-based method, what it does is it does a couple of things. So it changes the cervical mucus, and it changes the tubal motility, which is both of those things in conjunction are basically unfavorable for sperm to migrate up. So it stops fertilization in that standpoint. The other standpoint is when you increase your progesterone or progestin levels, it actually stops, if we go back to this nutty graph, the LH, FSH part right here, they're regulated by a hormone called GnRH, or gonadotropin releasing hormone. At higher levels, the progesterone actually inhibits that hormone. So you're not actually making or maturing a follicle, and you're not able to really ovulate. So it can actually stop ovulation at higher levels, which is what we see actually in the higher doses of progesterone and some of the IUDs that we place. Sorry, not IUDs, Nexplanons. In terms of the IUDs though, so the IUDs actually don't really affect the ovulatory cycle. What they do is they do cause changes in cervical mucus that basically stops sperm transport. And there's these inflammatory changes that basically kill sperm, and it makes it so that it's basically an non-inhabitable place, the uterus itself, for implantation to occur. So those two things are the really big mechanisms of how these things work. I included some other things that are relevant. So, the copper in and of itself doesn't have any hormones, so it's more of an inflammatory response. Whereas the IUD, the hormonal one, it actually thickens the cervical mucus and thins glands, which also makes it harder to implant. But that's just kind of like a basic overview of how these contraceptives work. I really like this chart. Unfortunately, it's in black and white. I wish it were maybe a little bit more colorful, but the thing at the top is a really good statement. Condoms obviously should always be used to reduce the risk of sexually transmitted infections. These contraceptive devices are not aimed towards preventing sexually transmitted infections. They're basically aimed at making sure you don't get pregnant. So obviously, if you want to prevent yourself from getting sexually transmitted infections, using a barrier method in conjunction with these methods would be the most appropriate. But if you go if you look at the top part of these set of diagrams, you have the most effective. On the left, there's the reversible category, which are the ones that we're talking about today. And then on the right are more permanent methods. So things like vasectomy for a male, which is male sterilization. And then things like female sterilization, or getting your tubes tied, is a more colloquial way of saying that. Those are very permanent ways of doing that. Whereas the ones on the left are things that we can reverse. When you look at this middle category, there's the things like the injectable or the depot shot. There's the pill, there's a patch, there's a ring. Those ones are variable in terms of how effective they are. They're anywhere from 4 to 8 women out of 100 will get pregnant in a year if these methods are used perfectly. So if I like to tell people that are thinking about getting birth control how effective these different methods are, and especially with the fact that if you're using these things perfectly, you still have up to an 8% chance of getting pregnant with these methods. So I think putting that in that context is important. And then this bottom category, it's more variable in terms of how effective. It's obviously less effective than the top, but things like the male and female condom, the withdrawal method, spermicide, using a diaphragm, being aware of when your ovulation is actually happening. There are more than 13 pregnancies out of 100 women in a given year. So you have about an 87% chance or less of preventing pregnancy with those bottom options. Which is kind of a good segue into the next slide, which is how effective are these methods really? So the Nexplanon is actually the most effective birth control method that we have on the planet right now. It's 99.9% effective in preventing pregnancy. And it's approved by the FDA for 3 years, but there is some more convincing data that can be effective up to 5 years. The World Health Organization has put out some research that says that we might be able to prolong having this particular method and have it be just as effective. So if you put it in the context of the last slide, you won't even have 1 out of 100 women getting pregnant in a year. It would have to be one step further. It'd be maybe 1 out of 1,000, which is a very, very effective way of preventing pregnancy if that's not something you want. The other ones are the IUDs, and they're both greater than 99% effective at preventing pregnancy. The hormonal method is greater than 99.8% effective. It can be used for up to 6 years. Other things that it can do is it can reduce heavy menstrual bleeding, the anemia. And then there is a condition called endometriosis where you can have really bad pain. It can potentially reduce pain from that. And there is some research that's shown that it can reduce your risk of getting cervical cancer in certain populations. So, really effective method, both of these, the IUDs as well as the Nexplanon. And then the last point I wanted to make about the copper, as I kind of already mentioned before, was it can stay in for about 10 years. So if you're totally sure that you don't want to get pregnant for many, many years, then the copper IUD might be the way to go. This slide, a piece of this is I want to make sure everyone kind of knows what happens in the process and what's going on with the procedure and how we do things. Both of these are minimally invasive procedures. They're in-office procedures. You're usually in and out within an hour. And they're very well tolerated for the most part. But I kind of wanted to just walk you through what we do with each of these things. So for the Nexplanon, what we do is we basically measure out, if you look at the inside of your elbow, there's this little bone that's jutting out right here. It's called the medial epicondyle. We measure about 3 to 5 centimeters from there. And we place it right here in the arm. I don't know if you can see me or if I'm just signaling something else. But we basically place it in this area. And we first basically clean the area. And we put some numbing medicine in that same area. And then the picture on the left is actually a depiction of, first of all, what the applicator looks like. So it's this top box. It kind of looks like almost like a ear piercing gun. There's a little needle at the tip. And that's placed just underneath the skin. It's advanced forward about the length of that same matchstick that you saw on that previous slide. And then the device is released. We just make sure that it's in there, a bandage is placed, and that's the whole thing. And then for the IUD procedure, it's slightly more involved, but to maybe just walk you through what we do is we do a pelvic exam, which involves a speculum. A speculum is a device, either plastic or metal, that helps us visualize the cervix. Once we see the cervix, it's cleaned with antiseptic solution. We place a device at the top, something called a tenaculum, that helps kind of stabilize the cervix. And then we do something called sounding. So we make sure that the cervix is able to have the device advanced through it. And we also want to make sure that patients are able to tolerate the procedure. And then more importantly, we want to make sure how long the uterus is to make sure that we're able to place the device appropriately. Once that's all done, the device is advanced. And that's kind of this picture here on the right that you see here. It's advanced in the T kind of opens up. And then this, the handle is basically removed with some strings at the very end. And the strings are cut, depending on who you ask, anywhere from 2 to 4 centimeters in terms of length. Those strings are later used to remove the device. We recommend for both of these, as a general rule of thumb, backup contraception is usually recommended for about 7 days following an Nexplanon or IUD insertion, unless it's a same day removal and insertion. So if you already have these devices in and you have it exchanged, then you don't necessarily need to have the backup contraception, but otherwise you would need to. So what are the side effects of these? So for the Nexplanon, it's possible where you can have longer or shorter or breakthrough bleeding periods. The most common side effect is breakthrough bleeding. They're usually highest in incidence in the first 3 months, and that decreases in the first year of use. And that usually kind of levels off and plateaus at years 2 and 3. There are other side effects that can happen, although, you know, some of the medical literature and the data that's there is not definitive. So I can't necessarily say that this is what will happen, but people have reported things like headaches or breast tenderness, and very rarely things like weight gain. But once again, I can't necessarily say it's 100% related to the Nexplanon. It could be other factors going on. With respect to the IUDs, the hormonal IUDs, you could have prolonged menstrual bleeding. That's usually the most common side effect, and unscheduled bleeding, and sometimes even stopping of your period. That's anywhere from 6 to 20% of people actually have stopping of their period. And then 20 to 30% can have some spotting as well. The copper IUD, one of the more common side effects are you could have a heavier menstrual period compared to normal. It's usually more common in the first 6 months, and it can increase bleeding by about 50% in some people, but it's not high enough and it's not a large enough volume where you're going to get anemic, where you're going to start having really low blood levels. Obviously, other things that I didn't mention for both of these are complications of the Nexplanon, very, very rare, but they do happen very rarely. Things like infection, if there's a pooling of blood in that area, it causes something called a hematoma. Some people have an allergic reaction to it, but once again, these are very low in terms of how often these complications occur. And then in terms of complications of the IUD, there is a possibility of IUD failure and expulsion. It's anywhere from 3 to 6% in the first year for hormonal IUDs, and it's anywhere from 3 to 10% for copper IUDs. There is some research that's being done in terms of why that happens. And some people, and there's some research literature that talks about people under the age of 25 may be at a higher risk of doing that, and that may be related to higher fertility rates. However, overall, it's a fairly effective method, and the risk of expulsion seems fairly low, especially in the patients that we place these devices in. And then obviously very, very rare is perforation, like uterine perforation in the setting of IUD. But once again, this is a very low risk. And I don't know, Dr. Sang can back me up. He's done thousands of these. So he probably knows better than I have, but I've never seen it. And I don't know if he has either.
I haven't seen that yet. Thank God.
And okay, let's see, what else we got? Got it. So when you decide the time is done, you want to either get pregnant or you want to try a different option potentially. I just wanted to include a slide about stopping contraception. So you can remove the Nexplanon at any time, but the brand maker usually recommends to be removed after 3 years. One of the things that I was looking through, and what I'm thinking a reason for this is because you're actually introducing hormones into your body. So you getting to a point of having a sustainable hormonal level, and then you having a fluctuating menstrual period and fluctuating hormones through your body, if it gets to about 6 months for you to get a good level, or even a year, if you take it out after 6 months, then your body's going to have to go through another cycle of having to re-regulate. So we usually recommend keeping it in for 3 years. Usually if people aren't going to get pregnant in 2 to 3 years, I think that's usually a pretty reasonable amount of time for them to leave it in. With respect to when they remove it, about 90% of people will begin ovulating after 3 to 4 weeks. And then the rest, it takes maybe a couple more weeks after that. But usually people are able to resume their normal ovulatory cycle after removing the Nexplanon. And then the IUD, you can take it out at any point during the menstrual cycle, and fertility will actually return immediately after removal. And another point that I wanted to make sure of was, even if people have stopping of their periods with an IUD, it's still possible that they're actually still ovulating. So if you've heard of people that stopped and they're worried about getting pregnant, that's another thing that that may be kind of in the works, but it's actually possible to still get pregnant afterwards, and it's not like you're not able to ovulate. So I put some resources in here. I used a couple of medical journals, but there's a really great website here called Bedsider. It has really good pictures and information about different birth control methods. And I thought was really cool is you can go on the website, and then if you're looking for birth control or family planning or anything along those lines, you can type in your zip code, and it can show you clinics and sites that you can get care. So I thought that's a really great website. They also have really cool articles on there too. And then obviously things like Planned Parenthood and the CDC have very good like interactive websites with respect to what kind of birth control methods might be best for you. These are the references I made. They're mainly just up to date. And I wanted to leave it open for any questions that you guys might have about anything I said, or other things. Dr. Sang might have to help me with some of them, but we'll see.
And we have the chat disabled, so if they want to go ahead and type their questions in the Q&A box, that'd be great. Or unless you want them to unmute.
Whichever they feel more comfortable with.
I guess I want to add one comment is that for those people that have a sexual transmitted disease, usually we like to hold the IUD until 3 months after the infection's gone. And again, like Dr. K mentioned, for those people that never been pregnant in a teen, they also can get this device too, and it does not cause any problem with infertility.
We have Chodney who's raised her hand. Chodney, I think you can talk. You want to ask?
Oh, yeah. Hi, Dr. Kishore. Just a question. If people have metal allergies, which is pretty common, like nickel, or do you think copper IUD would be an issue since it's also a metal?
That's a good question. If you have allergies to multiple metals like nickel and platinum, aluminum, any of these other things, I mean, there's a possibility it could be reactive and you might have an allergic reaction to it. So you might want to err on the side of using like a hormonal IUD or even a Nexplanon, because neither of those really have any metal parts in them. So that would be my recommendation, but I don't know if Dr. Sang has seen something different or wants to add anything.
That's true, but those things happen very, very rarely, especially a reaction to copper. So.
My only worry was that it's so long term. If sometimes allergies you don't have any, but you develop them later on once you're exposed to a metal. Okay, well, I appreciate your reply.
Well, Johnny, as you know, this IUD can be withdrawn anytime. If you have allergies, we can go in and take it off right away. So it's not anything that take a long time or anything.
Any other questions? Anything else you'd like to add, Dr. Sang?
Well, the only thing that I think in terms of IUD, sometimes we require the person to recheck their string every month or so for the first 3 months because there's a chance that the IUD could be exposed out, and those usually common on the first 3 months, but still very, very rare. And after that, mainly occasionally check the string, and that's all. And very, very simple how to do that. So usually we can teach the patient how to do that at the clinic too.
We do have a question. By Kelly, what is the most common form currently used for our 15 to 24-year-old age group?
I believe it's the IUD. I think the IUD is actually the most commonly prescribed birth control method in the world now. And I think amongst that age group, it would be IUDs. I don't know if Doctor's saying if that's inaccurate.
It's higher and higher now, but the pill is still the highest because it's not changing in terms of the statistic, but in terms of the long acting now, the percentage of people using that has been increasing significantly for the past few years.
Okay, and we have 2 questions from Chodney. How do you suggest clients to change their method of IUD since they are having so many spoofing issues for months?
Maybe spotting.
It must be spotting issues. Yeah.
Mm-hmm. Yeah, and I think that's an important question to ask. I think that kind of weighing a balance between effectiveness and potentially having the risk of having either more spotting or breakthrough bleeding is something that everyone would have to weigh. I think that it's a personal preference in a variety of different people, but in terms of effectiveness, the main talking point, I think, is the fact of how effective these methods are at preventing pregnancy, if that's what you'd like. And once again, I mean, a lot of the issues with spotting and abnormal uterine bleeding within the setting of using these birth control methods are within the first 6 months and a year, and sometimes those things kind of level off on their own. So.
Oh, we have
Again,
one more.
these are temporary issues. So usually we strongly recommend the patient to wait at least 6 months to a year before deciding to remove the device because again, like I said, because of temporary problem.
Yeah, we have another question from Chodney as well. Do you suggest to do anemic levels at that point when bleeding has gone on for months?
I didn't get the question, sorry.
Do you suggest to do anemic levels at that point when bleeding has gone on for months?
Go ahead, Dr. K.
Not necessarily, just because as I kind of touched on before, even if people have more than 50% increase in the amount of bleeding that they have, they rarely get to anemic levels. I would obviously kind of be a little bit more suspicious of doing blood work if they were symptomatic. So if they were really fatigued, really tired all the time, if they felt like they were having heart palpitations, if there was a variety of reasons of symptomatic anemia, then I'd obviously want to work that up some more. But generally, we don't check blood levels for anemia, even if you're having more than usual bleeding, especially with things like the copper IUD, because that's to be expected.
Okay. Bianca would like to know, when changing methods, i.e. pill to Nexplanon, when would you recommend that happen?
Yeah, that's a great question. So it kind of depends on what pill you're using and then when you're interested in doing it. So yeah, I usually talk to people about if they're on like a progestin only or combined oral contraceptives, estrogen, progesterone. Usually you're able to switch over fairly quickly. It's not like you have to taper off your medication or anything like that. So you're able to switch methods fairly fast. But once again, in that time frame, if you stop taking your pill one day and you get an Nexplanon that same day or the next day, using a barrier method for 7 days is what we would recommend. But it's something that you can switch over to fairly easily.
Those are great questions. We'll just wait a little bit and see if there's more coming in. Anything else you'd like to add, Dr. Singh, in the meantime?
No, I think Dr. K covered everything that I expected, and thank you, Dr. K, for a wonderful presentation.
So I think that's it. I don't see any more questions coming in. I'd like to thank Dr. K and Dr. Singh, and thank everyone for attending today's presentation, and hope you guys can join us on March 10th, Domestic Violence Women's Health Center.
Thank you all.
Thank you for joining. Thank you.